Hello friends, today we will learn about a special bacteria which you mostly encounter in your labs, that is a gram-positive cocci, and one of the most important cocci which is usually being isolated in most of the samples. It's very important when we talk about the samples which we get, also according to the question which we get in the exams. So many questions can come on this topic. So this is a very important topic. Now let's start. So what is this Staphylococcus? This is a gram-positive cocci. Basically, these gram-positive cocci mainly they are classified into two families. That is, one is the Micrococci, another is the Streptococci. So this Micrococci includes the Micrococcus and the Staphylococcus, whereas in the Streptococci, all of the streptococcal bacteria they all come in that family, and Enterococcus was also there. But the Enterococcus later on been shifted to a new family, that is a another family. Now when we talk about the Micrococcus, so Micrococcus and Staphylococcus both are catalase positive. Now these are gram-positive cocci. How you will recognize? First of all, the size of the bacteria is bigger in size as compared to that of Staphylococcus when you see under the microscope. And usually they are arranged in tetras. So whenever you see Micrococcus, they are in pair of fours. So four bacteria are there together, whereas in Staphylococcus, it is a cluster of gram-positive cocci. Now, Streptococci, it is a catalase negative. So when we say the first test which we do to differentiate between these two bacteria, Staphylococcus and the Streptococcus, so it is the catalase test. If it is positive, it can be Staphylococcus or Micrococcus. If the catalase test is negative, then it is Streptococcus. Now, the Streptococcus, they are arranged in chains or in pairs, whereas the Staphylococcus, they are arranged in clusters. So, whenever you see any GPC under the microscope, with the arrangement also you can have some clue. So this Staphylococcus aureus they produce, it is the most pathogenic species of the Staphylococcus, and it produces a special enzyme that is the coagulase. So aureus, that is Staphylococcus aureus, gives this coagulase as positive, whereas those which are giving negative coagulase they are called as cons. Cons means coagulase negative Staphylococcus. So how you reach to this? That is, first of all, any gram-positive cocci is isolated. Then first test is catalase. So if it is catalase positive, it is going in the favor of Staphylococcus, and if it is catalase negative, it is going in favor of Streptococcus. Then if it is catalase positive, so you will go for coagulase test. If it is coagulase positive, it is aureus. If it is negative, it is cons. So this Staphylococcus aureus produces the golden yellow pigment on the nutrient agar and beta hemolysis on the blood agar. Now virulence factor, this is also very important, how this bacteria is virulent to any person. So what are the factors which will support its conversion to the disease? That is cell wall associated factors like peptidoglycan, teichoic acid, cell surface adhesion, protein A, all these are helping this bacteria. Among the toxins, membrane active toxins are there, hemolysins, alpha, beta, gamma and delta, then leukocidin or PVL. So hemolysis, they are mainly lysing. Some are lysing RBC, some are lysing, when the toxin leukocidin, it is lysing the leukocytes. Then comes the extracellular enzymes. So like coagulase is there, heat stable thermonuclease, deoxyribonuclease, staphylococcus. So these enzymes are helping in spreading the infection of the staphylococcus. So what are the disease produced by this bacteria? When we talk about the skin and the soft tissue infection, it is one of the most commonly isolated from the skin and soft tissue infection. Like it can cause the infection of the hair follicle, or they can be furuncle, that is the pustular lesion. And carbuncle, if it is going more deeper, then it becomes carbuncle. Abscess if there is a collection of pus. Then it can cause mastitis, impetigo, surgical side wound infections. Among the musculoskeletal infection, it can cause the inflammation in the joints like the septic arthritis, or it can cause osteomyelitis. In the respiratory tract infection, ventilator associated pneumonia. Then post-viral pneumonia, it can be the causative agent, empyema, pneumothorax. So there are so many infections which can be caused by this bacteria. Then it can also cause the bacteremia, and there can be sepsis, or the patient can end up in the septic shock. Then the cons or the Staphylococcus aureus, both are responsible. They can cause the endocarditis, infective endocarditis. Then UTI, toxin mediated illness includes toxic shock syndrome, which secretes when the bacteria secretes the toxic shock syndrome toxin that has been seen in previously in the females who were using the vaginal tampons, highly absorbent vaginal tampons. So when the bacteria grows there, it will secrete this toxin, and this toxin is a type of a super antigen. Now the super antigen means it directly, without the binding to the cleft, it directly binding to the receptors. It does not need any antigen presentation, and normally any antigen stimulates 0.0001% of T lymphocytes. Here when the super antigen is coming, it is activating approximate 1% of the T lymphocytes. So there will be a massive stimulation of the T lymphocytes and massive release of the interleukins, which will affect the various organs, and the patient can end up in the shock. Multiple organ failure can also occur. So that is the toxic shock syndrome, which can be caused by the toxins secreted by the Staphylococcus aureus. Now another one is the food poisoning. So it is responsible for the food poisoning due to the aureus, usually by the dairy products, and it is due to the toxin enterotoxin. There is staphylococcal scalded skin syndrome. That is also a type of enterotoxin which can remove the skin from your body. It is the scalded skin syndrome. So that toxin is responsible for that. And one of the diseases is Ritter's disease, where this scalded skin can be up to 30%. So this you can see staphylococcal folliculitis, and another one is the abscess. So normally most of the, when we isolate Staphylococcus aureus, so usually they are pathogenic, but sometime in 20 to 40% they can be, person can be carrier of the aureus, and it can be present in the this antennae, oropharynx. So these are the sites where you can found it as a commensal, or the skin, vagina, axilla, or perineum. So these colonizing sites, they are reservoir for the future infections. So from there they can be moved to any sterile cavity or can cause the infection. Rate of colonization has been seen mostly in the those like diabetic patient, HIV infected patient, hemodialysis. So they can be having their more colonization of this bacteria. So in the laboratory diagnosis, how will you diagnose any case? That is, it can be a pus sample, it can be urine sample, it could be blood sample, or CSF, anything can come. So first of all, you do the gram staining of the sample. You will notice gram-positive cocci in the clusters, and some pus cells could be there. Then next step is the culture on the plate, blood agar or McConkey agar. Both the plates you have to take, and if it is some special sample like CSF, so there you have to take the chocolate agar. You have inoculator sample, the growth will come next day, and you will do the gram staining. You will notice gram-positive cocci, and then you will go for the motility. It will come non-motile. You want to check the pigment of the bacteria, you can grow that colony on the nutrient agar. You will notice golden yellow pigment. Certain selecting media available like mannitol salt agar, salt milk agar, and Rundlam's media. These media are especially being used when the sample is from some such site where you can have such other bacteria or the commensal bacteria can be there. So there you have to use the selective media. Now from the culture you will do the gram, you have seen gram-positive cocci, non-motile in cluster, and biochemical identification. First you will do the catalase test. So that is, we take H2O2 on the slide and we take the colony. With the help of the cover slip, apply to it and it will break down to H2O plus oxygen. That nascent oxygen will give the bubble. So it is catalase positive. Once catalase positive, go for the Coagulase test. So what will you do? You will take the slide, take a drop of normal saline, mix the 2-3 colonies of the isolated bacteria, make a milky suspension and then put the plasma. Mix it, and if you see some coagulation there, then it is positive reaction. Then, so once it is coagulase positive, it is Staphylococcus aureus. If it is negative, it is cause. Then protein A detection. You can also have the automated system. So this was the manual method. Automated machines are there like Vitec, Malitop. There you can just use the sample and you will get the report. Then antimicrobial susceptibility testing, that is the AST. So this you can see the first smear showing gram-positive cocci, and the pink you can notice these are the pus cells. So whenever you are directly staining the sample, so you will notice certain other cells also that will tell you that it is from the sample. Another smear you can see only you are noticing gram-positive cocci. There are lots of GPC there. So they are from the culture plate because there is only that bacteria has been grown. So you will not notice any other cells. Now this is nutrient agar showing the golden yellow pigmented colonies. Second is the blood agar. So on blood agar, if it is a pathogenic strain, so it shows the hemolysis. You are noticing the narrow zone of the beta hemolysis surrounding the colony. Now we come to the resistance. So in the resistance, which we have mostly seen in the Staphylococcus aureus, that is the MRSA strain, methicillin resistance in Staphylococcus aureus. This is chromosomally coded and the gene is the MAC gene. It alters the penicillin binding protein which is present on the S. aureus cell membrane. So usually this bacteria has the penicillin binding protein, and when the penicillin, whenever you treat any patient with the penicillin, so that penicillin will bind to this protein and it will inhibit the synthesis of cell wall of the that bacteria. But now the bacteria is very smart. So what it has done, it has changed its protein to a new protein, that is the penicillin binding protein 2A. Now the are these drugs which we are prescribing like cephalosporins or the penicillin group drug, they will not bind to it. So these beta lactams which inhibit this protein inhibit this protein, they will inhibit the cell wall synthesis also. But due to this alteration, it will not able to bind, and these MRSA strains are resistant to all the type of beta lactam antibiotics. So risk factors who all have more chance of MRSA, those who are having a poor hygienic condition, who are living in a crowded places, contaminated material, and with the damaged skin. So this MRSA, it could be of two types. One is the community associated or the hospital associated. In the community associated, this strain express MAC gene of 4, 5 and 6, whereas hospital one shows 1 or 2 or 3. Mostly these community ones, they are more virulent, whereas the hospital associated, they are more resistant. The community ones, they mainly cause the skin and soft tissue infections, whereas the hospital acquired, they cause the infection in the hospital and the nosocomial post-operative wound infections or the nosocomial outbreaks. Now, how we can detect MRSA strain? So, initially, as the name suggests, methicillin. So, we use methicillin drug to detect the methicillin resistance. But what problem the microbiologists have faced? That is, the results were not reproducible. Once you are getting resistance, next time it may not be the same condition. So they shifted to another drug, that was the oxacillin, 1 microgram. They were using the oxacillin. So the problem with the oxacillin was also that it was not telling up to the level of genetic. So we are saying if it is a MRSA, it is a MAC agent. So they shifted to a newer drug, that is a cefoxitin. If it is showing resistance to cefoxitin, it is also showing the presence of MAC agent. So that was why this test is preferred. So we are doing basically cefoxitin disc test, which are easily available. You can apply the disc, and if the zone is smaller than that, then you can say it is MRSA strain. Other than that, you can use PCR also, latest agglutination test also. Now, how we can treat those MRSA cases? So, we have the option of vancomycin. It is the drug of choice for MRSA, although in few of very little cases, the vancomycin resistance has also been noticed. Then you have to go to a newer drug, and these are, although these are the last drugs which are reserved drugs, and these are teicoplanin, linezolid, daptomycin, telavancin, quinapristrone and dalfopriston. So all the beta-lactam drugs should be avoided. Fifth generation cephalosporin is showing some activity. So that is very important. That can come as an MCQ. All the cephalosporins are not useful. Only the fifth generation showing some results like ceftobiprole, ceftaroline and ceftolozane. Which is the most important drug? That is the vancomycin. Then one thing important, that how can you, why this MRSA strain is important for you. When I am saying why this MRSA strain is important, that is when you are dealing the cases in the OTs, in the ICUs. So there, if the staff who is working and the person who are meeting those, that means the attendants, so they should be checked for the colonization of this MRSA strain. If any of the doctor, any of the healthcare worker is infected with this MRSA strain, so he should be treated. And once he is free from that, then only he will be allowed to do duties in the OT or in the ICUs in those areas where it is very important to not circulate this MRSA strain in the hospital environment. So that is all for the today. If you have any doubt, you can ask me in the comment section. Thank you for paying attention.